Welcome to our webinar. We're sorry for this technical difficulty. I'll explain what happened. There's this phenomenon called Zoom bombing, where Zoom calls are actually hacked and often explicit material is streamed without permission. And so during our last webinar with Dr. Bill Richards, we had a Zoom bombing incident. And so we enhanced our security, but perhaps a bit too much. Thank you for being with us today. I'm really excited about our webinar, and this is a topic that I'm really passionate about and active in, this notion of culturally attuned care, culturally responsible care, especially in the context of psychiatry and psycho-oncology. This topic is relevant to the equity, diversity, and inclusion conversation that's taking place with some systemic efforts to dismantle it. I think in mental health care, this is a very relevant topic. And for that, it's my pleasure to introduce Dr. Mojtahedzadeh, who is our psychiatrist at Mystic Health. She is a liaison, consultant liaison specialist, humanitarian educator, and has subspecialty training in psycho-oncology, in reproductive psychiatry, and palliative medicine, HIV psychiatry, and psychedelic-assisted therapy. She's someone who's dedicated to whole person care in oncology and beyond. And it's my pleasure to introduce her. So I'm going to pass the mic to Mona to also introduce herself. And Dr. Mona, if you can tell us a little bit about yourself, what makes you passionate about this topic, and perhaps just even defining, what is culturally attuned care?
Sure. Hi, everyone. Very glad to be here. Um, I uh, I am just very honored to be here, and I think that one of the I like how there's a lot of thoughts in my mind, and I want to get them out. But step by step, it just feels like we are living in this world where um, diversities are growing, whether we want to see it or not, and and as the diversity around us grows, by year 2042, it's reported that the majority of US population is going to be occupied by the minorities. So as this diversity grows, let's be mindful of the diversities within us that's also growing. And I think that's really like why I'm really passionate about this topic, because it can bring about a lot of dynamics within our life, just in relationships with ourselves, with the others, with everything surrounding us, and with our patients as clinicians. Um, and it is becoming a more and more harder job to be self aware, to know yourself, and to be connected to your true self inside. If you ignore and do not acknowledge all this, diversity is that's growing around you and simultaneously within us, within our bodies and our minds and our hearts, and just, so I think that's my passion. And my life experiences and work that I've done so far, working with patients from multiple populations, different backgrounds. I've worked with refugees, immigrants. I've worked with um, LGBTQ. I've worked with um, cancer population. I've worked with different, socioeconomic backgrounds, even within the, setting of the patients that I've witnessed. And I think that I see a commonality inside everyone. I don't see I don't see a major difference. Just like our genome says, 99.9% of our genomes are just the same. There is just that 0.1% that's different. And so I see a lot of similarities. At the same time, I see how beautiful our each and every individual is uniquely packaged. And I think that I don't want to talk too much, Houman. I want to allow back the microphone to you, but just that I think it is not a favor in this era. It is a professional responsibility of us to remain culturally humble and to practice cultural humility, honoring the cultural complexities in our world, which would help us at the same time to honor that within ourselves and just to have an easier, better quality life. So if you want to ask about meaning of culture, I like to go into deep roots, comes from the word cultura, and really it's about tending and evolving. So culture is not something that's just there, fixed, that's it, done. Culture is something that's evolving, it's dynamic, it's flexible. And I think that is the beauty of it. And that is because we're still alive. That's because it is an ongoing journey to get to know the different subcultures within us and to try to help the individual in front of us during the work that we do to recognize that and be able to be mindful about it, the strengths that it can bring to them about. Yeah, so there's a lot to go there, but I'll let you back the microphone and we can continue.
Thank you. That was great. There was a lot in what you said, and a lot that we could sort of get deeper into. I think one of the important things you mentioned is the notion of self-awareness, and this notion of self-awareness as a key component of emotional intelligence is really important one. And most people, view self-awareness as, how aware am I of myself? And that's one aspect of it. The other aspect of self-awareness is how am I viewed by others? And this is really relevant in this work in mental health, especially with psychedelics, where we have this notion of transference and countertransference, us projecting things onto the other. It's important that we know how we are perceived by other individuals. And so, as you said, there's increasing diversity in our communities. And, it's our responsibility to stay humble and open to keep learning. This notion of cultural competence that was originally defined in the 80s is now more framed with cultural humility because it's a lifelong process of learning. You may never become competent in someone else's culture.
Exactly.
Yeah, so I'm wondering if you can share, some examples of where you can use these skills of when interacting with a different culture. What are some examples of cases that dealt with where you've seen this applied?
Yeah. Yeah, Houman, I really liked what you touched on, who you think you are, whereas who you are seen by others. I think that's the bottom line of today's conversation, who we think we are or we believe we are, and then how are we observed by others um, after so many layers that's covered us, right? And so many different subcultures and life experiences that have shaped that. And I think that um, how does it feel to be seen or unseen? That's really my lens going into encounters and allowing the individual in front of me to be to express themselves the way that they want to see. So we need to carry a non-judgmental hat. We need to remain open. We need to be curious about knowing the people in front of us, whether it's within just relationship, in our personal relationships, or clinical encounter, which is, as I said, our professional responsibility, really. And it's not a favor. And because that's the least that we want to happen in a clinical encounter is that somebody comes in with shame and guilt, with feelings that's, suppressed cultural traits, because it is a different value system than the society that they're living in, the value system within their cultural system and the society. And that just is for and reinforced and fortified as they leave our office. And I think what modalities that I would recommend in order to be able to remain that open and curious and non-judgmental is to be able to really love our patients deep, deep down. And today's Valentine's, and I think I was looking for an excuse to bring this work, but I think that we need to love ourselves first to be able to love the person in front of us. And what does it mean to love myself? I'm not going to just love myself not knowing who I am, right? It is more beautiful when you know the stories, your stories, and you still love yourself, right? That's where love comes in. You know the stories of the individual and you still love them. And so I think that um, in order to be able to practice that compassionate care, genuinely compassion for the individual in front of us, we need to first have that compassion to ourselves. So I'm the number one an element or whatever human in this whole scenario that I want to be compassionate towards, meaning that I'm not, you know what, it is a whole therapeutic process, right? It is not just an overnight thing, but the picture to me looks like I want to embrace my different parts, just like IFS says, the internal family systems, we have different parts. Not all of them are managers, not all of them are what would protect us, right? Not all of them. Some of them are firefighters, some of them are exiles, our emotions that we don't really like, but we want to embrace all of those parts as someone who shaped at parts that shaped who I am right now today. Because some of them were survival skills, some of them were skills that I needed to obtain strengths that were strengths at some point. They might not be strength within the society at the time, but at some point they were. At some point I had to be silent and obedient, but right now in this day and age I don't want to be silent. It's better if I have a voice. So knowing all the parts within me and embracing them with respect, with understanding and compassion, that's the lens that I would carry, and that would translate into my clinical encounters and my relationships. And then, as I said, um okay, now different definitions of culture, right? We have different cultures. We have culture. We don't, not only ethnicity or race, right? We have culture of our occupation. We have a profession. We have culture of our gender. And also that depends on where we grew up, right? The gender terms are different. The responsibilities, the stereotypes that are implemented on us are different depending on where and which society we are raised, and or which family construct. And we have culture about like the art, artists. Houman, like you're an artist, so you have a culture, subculture of an artist. We have musician, have a culture. And even within the medical profession we have culture of institutions, whereas we have culture of like private practice model. They all have different cultures. So knowing that all of these subcultures can shape an individual, right? And I want to bring this up. So I consider myself a non-prolific but a poet. I'm not prolific poet, but I've written some poems and I really love. And I read a lot of poems, and one of them is Rumi, right? Rumi, from the 7th century. Okay, I translated, to be honest, I asked ChatGPT to translate this for me, but I'm going to read you the translation of this beautiful poem from Rumi, because that's one of my subcultures, right? I want to acknowledge it, and I want to be loud about it. Um, okay, let me find it. It talks about um, each one became, each person became a companion according to their own belief. So I am a mirror to other people in a way. If I am okay with myself, if I have good connection with myself, I can be a good mirror for others too, right? and and vice versa. The individual in front of me can be a mirror to me. And the more they're clear to themselves, the better mirror they can be to me. Um, so Rumi says, each individual became my companion according to their own belief systems, according to their own value systems and needs. But none searched within me for the secrets of my soul. And then the Farsi verse is beautiful. It's within the Masnavi book, and says, "My soul is not far from my voice, yet the eyes and ears are insensitive and unperceptive." So we want our eyes and ears to be sensitive and perceptive towards people, but that's not an easy job. We first want to be towards ourselves. That's the whole thing. That's the whole thing. That's the whole message.
Great. Thank you. Yeah, I'm going to go through some of the things you said. So, the piece on self-compassion is absolutely key. I'm fortunate to be part of faculty at McGill that teach mindfulness to medical students. And we actually had a session today, and the focus was on mindful self-compassion. And I think it's absolutely important what you're saying in terms of us loving ourselves to be able to love others. And in fact, in order to sort of maintain resilience and provide compassionate care without burnout.
Mm-hmm.
Another thing that you said that is wonderful is this notion of parts, the notion that we're made of different parts and, both internally and externally, and there's an interplay here. And so, I think that's a very important piece, especially in psychedelic therapy.
Mm-hmm.
And I just want to shift the focus to the psycho-oncology piece and bring an example of a case. And I know that you have similar experiences, but for example, my aunt was diagnosed with cancer. And in my culture, the Iranian Persian culture, it's not uncommon for patients to be unaware of their own diagnosis. And
Mm-hmm.
so in this case, my aunt who had cancer died without knowing she had cancer. And in
Mm-hmm.
fact, had she known she had cancer, she could have lived longer probably. So it's pretty unfortunate, this
Mm-hmm.
sort of communication. But it just goes back to the fact that, when you go and you have this encounter with a patient or a family, the first thing you need to do is understand who they are, where they're coming from, what they know about their condition. And, that's, I think, an example of culturally responsible care, because you can go in and expose a diagnosis that you would assume the patient should know, but that they don't. So, yeah, I was wondering if you can think of examples like that and any wisdom.
Yeah, yeah. Again, I want to think back. One thing I forgot to do today was thank each and every patient and mentors that I've had, that I've learned all of this from. And one of the we have also secret mentors, right? Mentors we've never seen, but they are our mentors. So Jimmy Holland is one of my secret mentors. She created this psycho-oncology field in Memorial Sloan Kettering, and I'm lucky to know her through wonderful colleagues and mentors, other mentors. So um, she talks about exactly the same thing, like that it does not have to be one way. We do not have a right or wrong way on how you want to approach your illness, your cancer, your life, um, life changing experience, and you want to find your own comfort level with this term. And family and individual, in some cultures families are very important, so the unit is not just individual. So in Western worlds it's more like the patient is the individual or the couple, but that unit might be a whole family, or in some parts of the world extended family members as well. So that is the unit. It's not like nobody's betraying the other person. It's the unit of that structure. And so they all come in with same voice, with equal voice, right? And so I think appreciating that what happened to your aunt, was the unit that was surrounding her with her. The idea at that time was that this is better comforting for her than to know the term cancer. And remember, cancer was the stigma still is high for cancer, even though we have so much. We've grown in treatments, and in fact, survivors are increasing now. So cancer rates are increasing. Part of it is also because people are treated, are staying more in survivorship, right? So I think that per what Jimmy Holland wrote in her beautiful Human Side of Cancer book, is that we want to find or encourage patients to find their own comfort level with this term, and but it's theirs to design. It's not ours. It's theirs to design. There's no universal attitude that would work when trying to address it. And you're important just to reinforce this notion that um, this person can be impacted by cancer, by earthquake, by wildfires, but anything, but they're still that person, and they're important, and they're valuable, and they should be respected. And the more like you clear to the yeah so they clear it for them how much they want to know about, like you need to understand how much they want to know, that unit, that patient, or the individual or the family unit that is emerging, how much they want to know. So you don't want to reinforce that this is wrong or right, right? Maybe that's their comfort level. And and remember, culture and personality traits and all that, again, per Jimmy Holland, they can affect how you behave, but not necessarily how your cancer behaves, right? And so I think, and then I want to go back to Dr. Breitbart's meaning centered psychotherapy from Viktor Frankl, and inspired by the book of Viktor Frankl, Man's Search for Meaning, that um, what are the things that you can really freely choose? One of them is attitude, and that's part of your meaning making. That is important for you to feel the freedom you have in the attitude you have towards your illness, and that's why I'm saying yes, we do have different cultural or subcultural attitudes in the face of suffering, right? Facing suffering, but we cannot say some of them are wrong or right. Obviously, we want to encourage our patients to all do what's best for them, right? But the attitude that they have towards that is their own. We can just help them to understand it, to recognize it, and to feel ownership over it. That is when the magic happens, because once they feel the ownership around surrounding their attitudes, then is the moment where they can be able to really hug themselves and hug those attitudes, and decide whether they want to keep it or they want to shake it off, right? So I think it is not easy, because remember, cancer diagnosis can be an overnight thing, and it shakes off the whole individual, the whole family structure. How can you expect the individual to change overnight in their whole value system, attitudes, everything towards what's the best in our books? We cannot. So we just need to allow them to express themselves. I think the more we can help them and gain their trust in us, in people can express more, and then we can build a team together. Me as the provider, patient, the other providers, and you know what? This team has like so many sub teams, right? Like inner rules within each division of our whole team, and we can craft and design a beautiful treatment plan together, right? I think that's where our help comes in. That's where we come in as supportive care providers to individuals who go through serious illnesses, um, because this is what we focus on more. And that is where we can come in and help the other providers to, like, as far as the lens that they want to carry, right? To now be more like questioning when they see the patient, as opposed to more directing and guiding. Like, be more like holding a more curious viewpoint of how do you see your illness? How do you want to see it? What do you think caused it? What meaning do you make out of it? What do you think the outcome of it is? How bad is it? And I can just go on, right? But at some point during today's interview and talk together, we'll talk about the cultural formulation interview and a little bit about that our DSM has formulated.
Great. Thank you. Yeah, I think the phrase that comes to mind is the notion of a beginner's mind, something that is used in mindfulness practices, but also in psychedelics.
Mhm.
Yeah, approaching it with that humility and curiosity, I think is the way to go. Many clinicians may feel challenged, especially, let's say, coming, from a place that's not as diverse as Los Angeles, let's say. If you're used to more of a homogeneous society, and now you have sort of new immigration and these patterns, and then so you have to adapt to sort of this new dynamic. And I think that's a fundamental way to be able to navigate the change. So I don't know if you have any advice for a clinician that may feel they don't have that sort of exposure and are transitioning.
Mhm.
Yeah,
Yeah.
talking interview.
Yeah, I think I don't have an advice because I stand next to them. I think that um, I do not know all the cultures in the world. I should not know. I mean, there are more than the individuals. As I said, everyone comes in as a beautiful full package. They're unique. So I think that it's just to, and I know that there is like this moral injury can happen because when you are faced with diversity and diverse cultural backgrounds in your clinical settings, it's not just your knowledge that's going to be required anymore, and it feels helpless at points within the clinicians, just as you're saying, and and then so I think like it's important to not feel like imposter at that time and feel like this is why it's happening and it is a normal feeling and it's because I am not responsible to know everything, but it is a part of my growth and I'm growing and just like everything is growing and then really ask the individuals in front of us to help us with that because they are the masters of their own minds and bodies, and or at least they want to be. And so we can, as I said, my really take on is to ask the individual in front of me to help me to build a team together. I think the most important thing that people want to know when they come to their clinicians is not that they want their clinicians to be the best master of everything in the world. They want to build trust. They want to feel trusted that this person really wants to help me. And that's when they can build teams together.
Yeah.
And I would just start with simple questions. So I think this is where I can go into this cultural interview. Within DSM, we have DSM, the Diagnostic Statistical Manual for Psychiatrists, is in some like it's in for our clinical work and to be able to formulate diagnosis and have it run through insurance and all that, we need to have that sort of kind of like Bible tool, right? And but in no way it is sufficient. I just want to acknowledge that in no way it is sufficient in and by itself in really encompassing this beautifully complex nature of individuals' experiences and why things are happening and what is actually happening. So I think that it is a great tool, and we want to use it, right? We want to use it when we always can benefit from it. So one of the things that VSM has is a cultural formulation interview. That's people like come together and came up with that. A lot of cultural psychiatrists, and it really has like a set of questions, like three sections. One is like some questions that asks the patient about like things that I already went over, like the definition of your problem in your own words and how would you describe it, what do you think caused it, and if you want, I remember you were asking about examples. I have patients that do come to me and talk about like this cancer is karma, And so that is one of the concepts and mindsets that's out there within some subcultures. And fortunately or unfortunately, through technology and media, we are just exposed to everything, so many cultures, so many subcultures, and so it is a harder and harder job to remain integrated and to really hold on to what works for us. But yeah, so some people, and I want to value that, and I want to value that some people do believe it's karma, and so it bothers them because they see it as a sort of punishment. In some people, a lot of religious and highly spiritual people, they see it as a spiritual path to purification, to more growth, and so that's another thing that it kind of helps them better face the suffering in that sort of way. And you can have people who think that it is from the repressed anger or not expressing emotions, and so that and I would never challenge them, because who am I to say this is right or wrong? But I would take that in, and if that is something that the patient really believes in, we will utilize that in the setting, turning it into a strength, how you can help facing your illness now, right? And to be more expressive, to be more, now we can get to know you better and craft that treatment plan, as I mentioned. uh, and then another question about cultural factors that have been affecting coping. So talking about coping, what coping modalities was useful for you before this? I'm sure everyone has had like challenging like experiences always, and so they can remember about the copings that worked for them and didn't work for them, to kind of bring that into the clinical picture and talk about it, and what are the coping that you want to use today. um, there are also some cultures that remaining silent and kind of like bearing the pain is a value, right? Um, a lot of like stereotypical traits that passed along to women in some parts of the world, or to men, also, like that, to not show it, not show your pain, and it is a value to really like burden it without people being burdened, because the idea is that I don't want to burden others, right? But so that's another thing that would really help to bring it into the picture and talks about it, and to see how we can modify that and adjust that and help the individual to carry it along if it is a helpful belief system still for them.
Ask your question, like the
Yeah.
patient that comes and says, this is my karma. How do
Hmm.
you approach that? Like, how would you respond to the patient? How do you navigate that sort of outlook?
That's most of the time a strong belief. Sometimes it is not, but if it is a strong belief and it is a fixated belief, I would not challenge that. But what I would do, I would go back to what they think was the root cause of this karma and talk to them about the root cause. Like, what do you think you did wrong at that time? And try to change that concept in their mind, that if you think you made a mistake at that time or you did it wrong, like it was not a mistake because it was something you did. Part of you needed that to be done for certain protection, for certain skills to survive. Or you maybe that comes from trauma, maybe that comes from like previous experiences that you've had. How much can we really control? How much is in our conscious really of our behaviors and attitudes? And so yeah, kind of just getting into the deep root cause of that, and allowing them to be friend with that part of themselves that they were. Because if they think it's karma, probably they are carrying pain from past. They're carrying some self guilt, some shame, and I think that's what needs to be worked on.
Thank you. Yeah, one of the concepts that we discussed in today's class earlier is this concept of mortality salience, this notion that is derived from terror management theory. And it's the idea that, all of us are going to die, at least until technology can change that. But that's one of the things we see a lot with cancer and other life-threatening illnesses, is this notion of mortality and end of life. And in my experience, having the privilege to do psychedelic assisted therapy, I've been able to help patients navigate that through
Mhm.
meaning making, through transcendence. So I'm wondering if you have any experience there, and what sort of tools can you use, to help patients navigating fear of death?
Yeah. Um, yeah, that's a good question because we don't want to change it. Again, there is fear of death, and um, some of it is just because we are all fearful of death, but really getting again deep into it, like what is it about death that's fearful? What is it about it? Is it the loneliness? Is it the pain? Is it the loss of dignity? Is it that you're going to be over? Your story is going to be over. Everything you did in the world is going to be faded away. And so, really approaching it from that sort of lens, that like it is, yes, it is a sentence simple as I'm afraid of death, but let's go deep into it. Where is it? What is it? And um, a lot of the times we have that lack of control, that I feel like that's going to take my autonomy away. Like I feel like, or approaching near death, or approaching like poor prognosis in my illness journey. It's I'm not going to be who I am, so it's going to be part of me away, my identity and my autonomy. And I think that um, just I would go back on the autonomy and the dignity preservation, and I would go back on the meaning making. Again, the meaning making, the meaning centered psychotherapy. Modalities from that, and really talk about sources of their meanings, and um, simultaneously address the pain, the like whatever fear of everything else that's there, but really also focus on you're not going to be done, like, and take advantage of any personal, highly personal spiritual beliefs, and or maybe religious beliefs that individuals carry that could help us throughout this conversation.
Yeah, that's exactly right. I mean, the research shows that people who are religious or spiritual generally suffer less from that sort of terror,
Mhm.
which is innate in the sense that, our biologic systems are designed to survive. We're sort of geared for survival, but
Mhm.
then have the capacity to rationalize this impending death. So it can certainly get complicated that way. I
Yeah.
was if you've had experience with caregivers, in the sense that, like, one of the dynamics that I've seen a lot in complex disease care is, for example, the patient wants one thing, and the
Mhm.
family, they want something else. And the example that vividly stands out to me
Mhm.
was this older Italian gentleman who really had, advanced end stage cancer, but his family, his wife and children, because of their love, just weren't ready to give up. And for them, they had to treat, even though there was a small chance of success. Whereas for him, he wanted one glass of red wine. He saw his death coming, and he wanted to enjoy the things he enjoys. And, this is something that I see often. Have you had experience with that? And do you have any advice on how to navigate these differences in approach?
Mhm. Like the patient is ready to let go and the family is not.
Yeah, exactly. Like, because families, they want to do everything they can for their loved ones. And
Yeah.
in their view, everything they can means the most toxic chemotherapy that has a very minimal chance of doing anything.
I would approach it from a family therapy point of view. Obviously, in these cases, like such as the example you're bringing, this patient is fortunate enough to have a good family, good number of family relatives, or at least one person who deeply cares about him or her, and So yeah, they are part of the unit. We need to bring them in. We need to do a family therapy. We need to talk to them and acknowledge the care that they all want to provide to the patient, and help them how to I think like really help them how to, I mean, really have a conversation, deep conversation with family members on where does that come from. A lot of family members carry guilt. A lot of family members um, carry guilt for so many reasons. Like, I didn't spend enough time. I wasn't seeing this coming so quickly. Um, we have another poem in Farsi, Persian, that says that like, I don't want the love after I'm dead. I want the love while I'm alive. So let's all appreciate each other's values and some sort of thing that way. But yeah, so really bring in. It's gonna be a session. It's gonna be beautiful. It's gonna be teary, but we're gonna acknowledge the emotions that's present there, and ultimately we're gonna hand the guide to the patient as the team leader, if that's what everyone would agree, if that's what patient wants, and have the patient speak up. And it's going to be a beautiful, beautiful family therapy session. And then um, um, if families are in doubt, sometimes families come to me and they're like in doubt, like how to approach this, what to tell the patient who's dying, right? And so what I've learned from the fellowship of the psychedelic assisted psychotherapy, one of the very good instructors with like um the best thing you can say is, and I tell them, if somebody wants like that a concrete answer, I tell them like, you just help them understand how much you love them and you're thankful for them for having been alive and being part of your journey, and that it's okay for them to go. You guys will all be okay. If somebody asks me like that, that sort of concrete answer, I will let them know. And that helps a lot of people. But yeah, otherwise, if there are really conflicting emotions and like decision makings in the scenario and everyone has equal voice, yeah, we want to approach it from that sort of family therapy model.
Yeah, thank you. Um, I'm wondering, looking at the landscape of psychiatry and let's say psycho-oncology right now, do you think there is enough awareness and training on this notion of culturally attuned care? How do you see this evolving? What sort of work needs to be done to make sure that, we're not causing harm while practicing?
Yeah, I think we are in a difficult era, in a sort of well, first of all, oncology has been advancing in the terms, in the sense of culturally attuned care, especially since 2015. Oncology treatments have become very much more personalized. As soon as the genome testing started to come out and people could get their genetic tests done to know personalized treatments, ever since years ago, then a couple years after that started more like growing in the sense of like, now in every care, every type of treatment that a cancer patient needs, we want to be personalized. So it is growing in that sense. um, that's sort of integrative care that we can provide to the patients, which is like really a whole person, and patient centered care, and a collaborative care and a consistent care model from diagnosis to survivorship, that is growing. At the same time, well, and that does encompass all these cultural humility concepts, and in the right way, if it's done, it should, right, like, encompass all of this. And as you see, like, we are all growing in that. It's an ongoing process, and we're learning, and we're having these webinars, and we're going to conferences, and so it is growing, and there's a lot that we still want to learn. But at the same time, um, it is difficult right now because sometimes it becomes there is resistance from the society. Sometimes there is resistance from the leaders, depending on what culture you are living in. or if you are in like what part of the world you are and what sort of value system is being run at the time in that society, right? Um, well, we cannot control that, right? Can we? We cannot control everything. But one thing we can do is to look at history. And a lot of the cultures who were facing resistance eventually succeeded because throughout those periods of hardship and resistance and the obstacles that they were facing, they were there was a processes that was going on underneath. There were processes that was going on within each and every one individual that was not seen, but it was going on, and that was meaning making, and that was resilience, and that was like generativity. That's another part of meaning. Like people are becoming more like inspired to do something to help the community, to do something to help another human being. And so I think that sort of thing is going to be growing also, and that's going to help the hardships that might or might not we or anywhere in the world face throughout this ongoing journey of growing in the more, like kind of be culturally attuned care, responsive, and um, just more compassionate towards clinical settings.
Thanks. Yes. One of the things that comes to mind, you brought up the DSM, and we're talking about this culturally attuned care. And one of the things that comes up for me is, for example, how different cultures approach something like psychosis. Psychosis is something that's been happening likely for, hundreds, if not thousands of years. And,
Mm-hmm.
not everyone approaches it the same way that we do in the West. Some cultures view it as a gift.
Mm-hmm.
And so I'm wondering if you have any experience with that and any wisdom to
Mm-hmm.
share, perhaps for someone that is, more by the book, and
Mm-hmm.
how can we be a bit more non-judgmental in our approach?
Yeah, I like this question because a lot of our altered states of consciousness actually does have psychotic experiences. Like we might have like, you know, again, we don't want to stereotype and bias everything, right? Like and symptoms. We don't want to go into the evaluation with a bias, right? That because the previous patient I saw had hallucinations and ended up admitting because like they were having command hallucinations to kill people, or other things, whatever. But this person in front of me is also like acute, and we need to do something right now, and we need to just take this away. So yeah, I want to put that lens away. Again, go back to the poem I read and go back to what do we see and what does the patient see. And so I, for example, had a patient who had a end stage prostate cancer and had auditory hallucinations of his mother, and that his mother had passed away obviously years ago and years prior, and those hallucinations were really comforting and warming, and really made sense to him in the journey he was carrying. Why would I want to take that away? It wasn't harming him or anyone. And in fact, his wife was also laughing about it, and she was like, I'm okay, I like him more this way. And yeah, so and then another way of like hallucinations that could be a manifestation of psychosis is within the altered states of consciousness, as I said, like grief, like deep grief. We have hallucinations from the individual who passed away, and that's not necessarily an abnormal pathologic thing. And yeah,
Yeah,
so we will take it case by case, not one size fits all.
thank you. I'm wondering if you have experience with dreams. I know that, especially as we enter end stages of life, dreams can become more vivid and more meaningful. And,
Mhm.
obviously, they could be a window into our subconscious. So I'm wondering if you have
Yeah.
any experience or any ideas about that.
Yeah, I have a beautiful example. I just don't know if it's appropriate this setting to bring that up, but it just happened from 2 nights ago, one of my own dreams. I think that honestly, dreams can be a window to our subconscious, but they don't have to be, right? It's us to make meaning out of them. So I don't like the idea of I had this dream, and in my dream, whoever that I really love died or had an accident, and live my rest of the days in fear of what if I lose that person because I had that dream. But uh, I mean, it's a personal right choice. But I would say that our dreams could be a window to our subconscious, and so they can be very beautiful in that sort of way, and we can and the more we actually try to remember our dreams, we can ignore it, we can actually neglect it. The other day, someone I know came to me and said, I have dream catcher. I said, what is that? And they said, it catches all the negative dreams I have, so I need to have this dream catcher in front of me every time I sleep so that I have only good dreams. I was like, perfect, that works for you. And it really does work for them. Like, it's like everywhere I go, sleepover or whatever, I take the dream catcher with me. So I think it's very personal, and I think that we can interpret it in our own ways, and yeah, and be making meaning the way that works for us out of it.
Amazing.
And that also is a great tool in therapy. We can bring it into our therapy sessions, and um, and discuss it with a therapist about it, and use it as a tool.
Great. Have you had any experience with lucid dreamings? One of our participants is asking Dr. Singh if you've had any experience with lucid dreaming in sort of sleep, wake states.
Oh, like hypnagogic hallucinations,
Yeah.
or like dreaming, but you're in the lucid. Yes, in fact, that's a good question, because if you review sleep cycles, our sleep cycle starts with stage 1, 2, 3, and then we go into REM. And REM is where we remember our dreams, right? So we start the night with less frequent REMs. As we approach the morning, we have more frequent and longer REM periods. So we usually remember those dreams that we have like early mornings. And if we are like, our clock rings, and I've had experience where like, I don't want to wake up, I want to stay in that dream. Yes, and they're very, very like vivid, and they're very real to us. And I think that we humans are not just living in the outside of our dream. I mean, the fact that we are actually sleeping 1/3 of our days, if we're lucky, um, it says something about our journey in this world. And so our journey is not only the times that we are awake, alert, happy, active, working. And I think we should really take care of our dreams, and we want to respect it and get to know it if it helps us.
Thanks. That was very informative. The same person is asking, this notion of lucid dreaming. When I first learned about it, I was in college, and Carlos Castaneda had these books on lucid dreaming, and this shaman master that he had, Don Juan, where they would essentially put intentions and do these journeys in the dream world, maintaining some degree of lucidity and consciousness and memory. I later found out that it wasn't necessarily as accurate as the books had depicted it to be. But have you had any experience with that? Like, sort of the term used is like controlling dreams or setting intentions for dreams and going on a journey.
Um, no, I would like to hear more your thoughts on that, Human. How about yourself?
Yeah, no, I don't have as much experience, but what's interesting is, so we have this plant in Iran, as you know, esfand, and esfand, which is called Syrian rue in English, basically contains a bunch of molecules, these alkaloids. Some of them are monoamine oxidase inhibitors, which is one half of the ayahuasca brew. And
Mm,
so esfand contains that, but it also contains a bunch of other chemicals that induce these dream-like states. And apparently, because we had this ancient brew called Homa, in India they call it Soma, And they used to enter these altered states with this brew, and it's debated what the actual active ingredient was. But basically, apparently, that is one thing that can be done. And one of my friends, Shaheen, has a company now called Magi, and they produce supplements, and these are legal supplements that contain these sort of dream-inducing states. And I
Mm-hmm.
still haven't tried them, but it's my intention to do so.
That's beautiful. I love that. And I want to see what we get out, what we're looking to get out of it, right? Like as we talk about these beautiful experiences of altered state of consciousness, like each and every one psychedelics have like different impacts, right? And one of them is like the whole um concept of like self-dissolution and being part of a broader whole, right? And I think that's one thing that dreams help us with. It's not, it's just you're bigger than what you see in you. You're part of, and also you're part of a whole. You're part of a whole. You're part of a bigger thing. And just reinforcing the concept of energy around us and our soul being a lot more broader than what even we think it is. Um, and I think that helps us a lot within the whole concept that we were talking about, compassionate care and being culturally attuned. One of the things that I was actually studying with, like, for example, these empathogenics, what they do is we want that, right? Like the extreme serotonin release actually is empathogenic, but then also um, having support groups, having strong emotional responses, having deep conversations, having shared struggles, and like talking to people about our shared struggles, music and dance, which, as I said, they have their own beautiful culture. All of this, and our dreams, and this whole concept of knowing that, like, being able to really connect with our souls better. I think all of these could be playing a role in as an empathogen and help us really connect with ourselves, better.
Thanks. Yeah, what comes up for me is you are not a drop in the ocean, you are the entire ocean in a drop, or something like that. And
Yeah.
what you brought up is actually the philosophy of mystic health, and why I named it mystic health is really that concept of maintaining awareness, about the temporary nature of this experience of the ego construct, which is a very useful construct, having its limitations, that
Hmm.
perhaps we are part of something greater and timeless. And so I'm glad that you brought that up.
Yeah. I am glad that you brought that up too. That's such a beautiful philosophy, and the name stands like Sufism, mystic, and it just is very relating to people these days. Also, and
Yeah,
I'm sure a lot of people can relate to that.
much needed in our society. Matthew is suggesting a book called Decoding Your Dreams by Robert Langs, MD. So if anyone wants to read more on that, I haven't
This
read it.
is Matthew Loscalzo, who is the author of so many books in psycho-oncology, and I am very honored that he was able to join us today.
Thank you, Matthew. Thanks.
Yeah.
Um,
Thank you for the book recommendation. I hope we could be interactive, more interactive, and see the participants.
for sure, yeah, we can actually open up the question as we're approaching end of the webinar. If anyone has any questions or comments, Kabir, if you're able to, you can open it up if anyone
Sure.
would.
Yeah, I'd be more than happy to.
Wonderful. Yeah, if anyone wants to tune in and ask a question, please do so. Mona, as we get ready to end our session, I'm wondering if, uh, you know, if you were to say you want to see a certain change in how mental health care is delivered in our system today, um, you know, where would you start? Like, what sort of thing would you recommend?
Mm, yeah, I don't want to like preach on that sort, but like how to I think that there is actually, that's the whole thing. We do a lot of slogans, but actually implementing what we say, like practicing what we preach, that's the sort of change I want. it's not like one single action that I would say I would want to change, but it's just like, I can like talk about so many actions in the most beautiful words in the world because I read from the books, right? uh but who would care, right? Like, we want it to actually be implemented, and I think that we have the knowledge. We have, like, as a society and individuals, we have a lot of knowledge, and we're growing. We're all, but people are really enthusiastic to learn more, and because we all need that, and especially in the age as technology is advancing. And don't get me wrong, technology is not necessarily bad because it helps us in its adoptive help is to help us actually feel we are part of a whole. We are part of a whole through the technology and media. And but it could also be a distraction from our pain and approaching ourselves and approaching and connecting within us. And and that distraction actually allows everything in the society to become more superficial. And I think that's what we don't want. We don't we're People are tired, and not that just tired, we are all like, we can't handle it. We can't handle superficials anymore. We want deep, real work. And I think that that's what I'm talking about. Like, I love these webinars, but like, we all talk a lot, but actually getting it done, and it starts within individuals, starts within me, starts within you, it starts within my neighbor, and little by little, it can grow. But really focusing on what needs to be done and what can we do in the capacity that we have.
Thank you. Yeah, that's really profound. And from my view, and it's a little bit similar to what you're saying, it's a little less, over intellectualization and more towards action and heart.
Yeah.
And back to your comments on love, which I feel like in family medicine, where it's a bit easier for us to use it, but in psychiatry, there are these strong boundaries that are set, and understandably so for many of the
Mhm.
intense cases. But thank you so much for the wonderful talk. And I'm just going to see if there are any other questions that we haven't addressed. And yeah, and Sheila, my friend and your cousin, is asking if ketamine therapy is used in palliative care. That's a wonderful question. Actually, it is used in palliative care. We do offer ketamine therapy in palliative care. And my work at McGill, we're actually doing some research on ketamine therapy in palliative care. The reality is that there's a paper published last week covering all the research that's been done, and there's a lot of evidence for its benefit, but there are smaller studies, and so a lot more research needs to be done. From an anecdotal perspective, I can say that it does work, and the evidence shows that it has certain advantages over other psychedelics because it's also an analgesic, so it can help with pain. And for a lot of people suffering from pain over months to years, it gives them an opportunity to actually have a break from the pain while having these profound mystical experiences. So we're excited to be offering that now at Mystic Health. Lovely. Any final words, Mona John?
No, just congratulations on the work you're doing and your colleagues. And I want to acknowledge all the beautiful work that's been done. And because of people who had the hearts to go into doing things, and I want to thank everyone who we are constantly learning from by being brave enough to share their journeys. Um, and I want to acknowledge that their stories are never lost. It is carried within our hearts as their providers, and it will be passed along to the next ones we will see um, in a more meaningful way and help us do better, meaningful job and better be able to take care of people.
Thank you so much. That was beautiful. Thank you, everyone, for joining. We will be putting this webinar on our YouTube channel. So our social media handle is at mystic.healthy. So we have a Mystic Healthy team, and look forward to seeing you in future webinars. Thank you, Mona. Thank you, everyone.
Thank you, everyone. Bye-bye.
So, bye.